Okay, so I'll be talking toric IUL surprise. What next? So we put on a toric IUL, and if the patient still has got astigmatism, what are the options we have? Realignment of the toric IUL, exchange of IUL, piggyback IUL, or a laser correction. So whenever we want to do realignment, I will like to explain certain terminology. One is that we need to know after surgery what is the total refractive astigmatism patient has got. What is a keratometric astigmatism now, not pre-operatively, post-operatively? What is the total correctable astigmatism by the IUL? And what is the residual non-correctable astigmatism? That means if suppose patient had a corneal astigmatism of 2 and you have put on a toric IUL which can correct only 1, that means one diopter cannot be corrected by the realignment of the toric IUL. And at the same time, we will like to know what is the residual correctable astigmatism. That means what was, if the IUL was in ideal position, how much it would correct and how much it is correcting. So we need to analyze these data before we can plan for realignment. And we always align the axis, misalignment, and the correction is the byproduct of that. So we need to know how much is the misalignment. As we know that the degree of misalignment, if it was 30 degree, the residual correctable astigmatism will be total correctable astigmatism. That means if the IUL is 30 degree misaligned off axis, there will be no effect of the IUL onto the corneal plane. With that in mind, if we know that how much is the misalignment, we know that if the misalignment is more than 10 degree, then we can go in and try to correct it. Between 5 to 10 degrees is questionable, and below 5 degree, we will not like to correct it because we are not 100% sure whether the realignment is going to help. So to find out the residual correctable astigmatism post-operatively, why I'm emphasizing whatever was the pre-operatively is gone. Now after doing the main incision, whatever is the steep axis now is more important. So what is the total patient has got a refractive error, whether he has got -2, -1, -3. What is the corneal astigmatism at present? What is the steep axis and what is the astigmatism? And what is the IUL which can correct? Now let's say if the patient has got a total correctable astigmatism, that means IUL can, I have taken it in very simplified manner, is one diopter at a corneal plane. And if there is a residual astigmatism of 0.5 diopter, that means the misalignment is by 15 degree. And if it is a 2 diopter lens, then 0.5 diopter of correctable astigmatism is, that means misalignment is only 7.5 degree. But if it is a 3 diopter, it is 5 degree. If it is a 4 diopter, it is 3.75 degree. And if it is 6 diopter correctable IUL, and if there is a 0.5 diopter residual astigmatism, actually misalignment is only of 2.5 degree. That means, and if you take a 1 diopter, usually we don't correct 0.5 diopter. A 6 diopter IUL giving an error or under correction of 1 diopter, actually misalignment is only by 5 degree, while 1 diopter IUL, 1.5 diopter IUL, which is correcting 1 diopter, misalignment is by 30 degree. That means the 1 diopter IUL, which is giving 30 degree misalignment, can be corrected, but the 6 diopter IUL, which is correcting the misalignment error of 1 diopter, only 5 degree of misalignment, probably you will not attempt. So it is very important to understand in relationship what we have achieved and what we should have achieved. That proportion is very, very important. So realignment is done when there is significant misalignment, and it can be corrected significantly. So now I'll give you one example of my patient, 67 years male. On 21st of January, the lens star reading was 1.39 at 92 degree. Pentacam at 3 millimeter was 1.5 at 93.5. This was total corneal refractive power. And when they saw the patient on 6th, it was a multifocal toric IUL. Uncorrected distance visual acuity was 618. Best corrected visual acuity with 1 diopter of spherical -1 diopter slender at 30 degree was 6.6. And then we again calculated the keratometry. At present, the lens SR keratometry was 1.56 at 94, and pentacam at 3 millimeter was 1.6 at 95, because Indian people are little smaller, so I go by 3 millimeter most of the time. But at 4 millimeter, it was just 1.1, and it was 81.4 degree. So correction achieved by the IOL was more or less 0, and you can see the IOL is mispositioned. So we plan for the reposition of the IOL to the present steep axis. I'm emphasizing again and again that you don't have to really go to the astigmatismfix.com or ASSORT or any other site, because whatever is the steep axis now, you put the IOL there. If you feel, until unless your surgical induced active astigmatism is too high and you don't have to open the main port incision, just make the side port incision and implant the. So now if you see this, there is a mark on this, which is I'm marking now 90 degree, and with the 92, 93 at 3 millimeter and 81 at 4 millimeter, I'll be quite comfortable putting this lens at 90 degree. So my way of marking is I take a chopper, give the indentation over there with the chopper, and then put on an ink which stays there longer, or even you can put this chopper into the marking pen and mark over there. And then I put on an ink over there. So this axis is now being marked where I want my L to align. Though I took this picture on a slit lamp with the app available, and it showed 42 degree misalignment. But to my mind, that is not important until unless the astigmatism is too irregular and you are not sure. So I prefer to put it, the side port incision is open, which was made earlier, nearly a week, 10 days earlier at the time of surgery. You make another side port incision. I usually make one side port incision. Hyaluronic acid is the preferred viscoelastic over here. I go underneath the rim of the anterior capsule and inject little bit of viscoelastic over there. And this lens is, at present, the capsule is, you can see the capsule is not so fibrous. There is no whiteness. So lens can be very easily lifted. So I put on a viscoelastic in the bag, and then this lens is redialed into the position. You can do the hydro redialing also as we do the hydro implantation, but I'll prefer to use the hyaluronic acid over there for the better separation of the capsular bag can be done. So you can see that one loop is being moved, but the other loop has not rotated because of the knee, which is very flexible. We separate the anterior and posterior capsule by sweeping with the iris reposter. Then we go and separate if by any chance there are any other additions onto this side. And the same iris reposter is used to dial this lens into the new position. And we know that the lenses are to be dialed into the clockwise position, even if you need to dial more, and make sure that there are no additions and they should be lifted up and well. So now I use a dumbbell dialer to position it. And once this lens comes into the position, we need to remove all the viscoelastic, whatever is there. And particularly if there is anything behind the lens, that has to be definitely removed. So we position the lens. And the lens is now at a right position. We remove the viscoelastic. You can see a small air bubble behind the lens. That also shows that there may be some amount of viscoelastic behind. So we go lift the lens, go underneath and take it out. I really don't want this lens to rotate again. Otherwise, I'll have to go and rotate 180 degree once again. If need be, of course, you will have to do that. There should be no doubt about that. And once this is done, viscoelastic is removed. We inject the air before coming out so that the lens is pressed, and make sure that your wound is well sealed. I put on antibiotic drops again over here, put some air, and press on both the sides with the swab stick to make sure that the wound is well sealed and the surgery is over. So this residual refractive error in this patient was 0.25 diopter spherical and 6.6. There was no astigmatism. Pre-alignment was +1 with the minus 1.5, and this spherical equivalent was 0.25. Minus 1.5 cylinder is equivalent to minus 0.75. This is very important to understand the spherical equivalent, because non-correctable astigmatism, realignment will not work if this spectral error is more. That means if the patient has got 2 diopter of corneal astigmatism, and you have put on a lens which corrects 3 diopter or 1 diopter, it is not going to work. Or if the spherical equivalent, that means patient had minus 1 diopter of spherical and minus 1 diopter of cylindrical, total spherical equivalent is minus 1.5. That means the spherical equivalent is going to remain the same. It is only which is astigmatism is going to change. So if there is a refractive error, it is not going to be corrected by the realignment of the IOL. If there is an irregular astigmatism, it is not going to work. If there is a junior dialysis, PCT, or the fibrosis of the capsule, sometimes if the capsule is too fibrous, maybe after 3 months or so, it may be very, very difficult to place the lens into the new position, because the separation of the capsule may be very difficult. So it is better to do it early on. And other options are, of course, laser, which could be LASIK or PRK after 3 months. And particularly, there is a high spherical equivalent. That means if there is a refractive error along with the astigmatic error, and if there is a non-correctable astigmatism, then this is the best option. And IOL exchange, I prefer in a hyperopic spherical equivalent. That means if the patient has a hyperopic, now if the lens has been put underpowered and he has got a +1, +2, because the LASIK may not work so well in hyperopic patients. And piggyback IOL can be used in the reversible option. If there is irregular astigmatism, the patient is not interested in any contact lenses and spectacle, and you want to see whether the toric ICL or toric IOL works over there, and if patient is not happy, you can remove it, then piggyback IOL can be used. Now, otherwise, the laser, if you got an option of a laser, I think it works very well. And thank you very much for your kind attention, and any other comments from the panelists.